I'm delighted to introduce one of the interventional radiologists here at MD Anderson. And Dr. Sanjay Gupta has been here at MD Anderson in Department of Interventional Radiology, and we've worked very closely together on management of patients with GI stromal tumor. And he's really, I would have to say, probably the lead authority globally on the management of GI stromal tumor through these type of interventional radiology methods. And I'd like to thank Dr. Gupta for taking time out of his Saturday morning to spend with us here, and I will turn over the podium.
Thanks for that kind introduction, and I would like to thank Barbara and Dr. Trent for inviting me to participate in this session. So basically, Dr. Trent asked me to talk about the role of interventional radiology in the management of patients with gastrointestinal stromal tumors, especially those who have metastatic disease to the liver. For those of you who are not familiar with interventional radiology as a subspecialty of radiology has existed for almost 15-20 years now. And basically what the interventional radiologists do is do minimally invasive procedures using image guidance. Basically we use small needles, guide wires, or catheters to perform minimally invasive procedures using image guidance. Basically these images provide us roadmaps of the body, and we use those roadmaps in a real-time fashion to allow us to take these needles or guide wires into the area where we want to go and do the procedures we want to do. And these procedures can be both diagnostic and therapeutic. Some of the diagnostic procedure basically is biopsy. You have a lesion inside the body, and the only way to get to it is using either a surgery or to use image guidance, and you put a needle into that area to make sure we are in the correct area and we're not injuring any other structure, and then take a sample of tissue for biopsy, mutation testing, which is definitely required before the treatment can be begun. So, as you all know, metastasis is common in gastrointestinal stromal tumors, and liver is the most common site of metastatic disease. And before the advent of Gleevec, liver metastatic disease was extremely resistant to most of the conventional systemic chemo agents available at the time. However, Gleevec has changed all that, as Dr. Trent talked in his earlier presentation today, and the response rate can be achieved in as high as 70-85% of patients. Unfortunately, there are a small number of patients who do not respond to Gleevec, and there's another small group of patients who, after initial response, may acquire secondary resistance to Gleevec and may have progression of the disease in the liver. And obviously, there are new agents, tyrosine kinase inhibitors available, which can be used in patients who develop resistance to Gleevec. So if you have a small progression in a liver disease in localized area, and even despite Gleevec or sunitinib, the only curative option is surgery. However, only very few patients are eligible for surgery because they may have too many lesions in the liver, or based on the location of the lesion or the size of the lesion, they may not be eligible for surgery. And those are the patients in which, as interventional radiologists, we can offer some local or regional treatment for liver disease. Although there are a number of liver-directed treatments available with interventional radiology, I'll be focusing on the three which we routinely use in this subgroup of patients. The other treatments like radioembolization have not been used for GI stromal tumors. So one way of treating those localized progression is ablation. Basically, we place a needle in the tumor, and either we heat the tumor or we freeze the tumor. Either way, we can basically kill the tumor cells. The freezing tumor is called cryoablation, and heating can be done by 3 different energy sources which are currently available: radiofrequency ablation, laser ablation, and microwave ablation. Radiofrequency ablation has been available for a long time, and we have the maximum experience with radiofrequency ablation. That's what I will focus on in my talk. Another way of treating those liver lesions is basically doing either hepatic artery embolization or chemoembolization. In embolization, basically, we inject particles into the vessels which are going to the tumor, with the idea of depriving the tumor of its blood supply and causing tumor cell death. In chemoembolization, we mix the chemotherapeutic agent with the particles. So it's a mixture of cytotoxicity of the chemotherapeutic agent and the ischemia caused by embolization. And the reason we can safely inject particles and block up the blood supply to the liver or the tumor is because of probably liver is the only organ in the body which has kind of a dual blood supply. You have hepatic artery, which brings the blood to the liver, as well as portal vein, and both of them supply the liver. Fortunately for us, the tumors, 95% blood supply to the tumors comes from hepatic artery as compared to the normal liver, which derives 75% of blood supply from portal vein. So as long as the portal vein is open, we can inject particles in the hepatic artery and cause damage to the tumor as well as some normal liver without any significant risk of causing liver damage. Basically just a cartoon showing the tumor here. These are the blood vessels which are supplying the tumor, and this is a small catheter that we have placed in the vessel supplying the tumor, and then we inject these embolic particles into the tumor which go into the smaller blood vessels and eventually cause the shrinkage of the tumor. So as I mentioned, it's hepatic artery embolization or chemoembolization. Embolization works by hypoxia alone. You block the blood supply and then kill the tumor. And in chemoembolization, you're adding hypoxia plus the chemotherapeutic agent, which has its cytotoxicity. The advantage of injecting chemotherapeutic agent directly into the tumor is obvious. Then you can get a much higher dose as you can get from systemic administration. And various experimental as well as other studies have shown that you can get a drug concentration as high as 10 to 15 times higher than what you can achieve if you just give a systemic or IV dose of the same chemotherapeutic agent. And in addition, we are injecting particles after the chemotherapeutic agent. So what it does is it traps the drug in the tumor and prolongs the contact time between the tumor and the tumor cells. The drug and the tumor cells, potentially increase the chances of cells dying from the chemotherapeutic agent. And obviously, since very little of the chemotherapeutic agent reaches the systemic circulation, side effects are minimal. And this procedure is generally done with local anesthesia and some minimal conscious sedation. As I told, we do minimally invasive procedures. Somehow we have to gain access to your blood vessels. The easiest way to do that is in your right groin area. The femoral artery is very superficial. We can easily puncture it. And then we can take a small tube into the femoral artery and then take it up through your body, your vascular system, into the area of the liver, basically the hepatic artery which supplies the tumor. And we use real-time X-rays to guide our catheter into the correct place. Just to show an example, this is a catheter which has been placed in the celiac axis. Celiac axis is the vessel which basically gives origin to the hepatic artery which supplies the blood to the liver as well as the tumors in the liver. And once we get the catheter in there, we inject some dye to get a roadmap of what's going on there and look at the hepatic artery and see which vessel is actually supplying the tumor. And as I mentioned, the reason we can do this is because of the portal vein which supplies the normal liver. And so we want to make sure the portal vein is open. Sometimes a tumor can press on the portal vein or invade the portal vein and block the portal vein. So the portal vein is blocked, then we cannot do this procedure because if we take away the only source of blood supply to the liver, the portal vein is gone, then we can cause liver failure. So we study the portal vein to make sure the portal vein is open. Just to show an example here again, dye study which we call angiogram shows these vessels going to the liver, and we see some tumors on the right side, and we also see some tumor in the left portion of the liver. But when we study the portal vein, we see the portal vein branch on the right side, but in the expected location of the left liver, we do not see any portal vein branches, and we see sort of this filling defect here, which shows that the left portal vein is completely blocked. So in this case, we cannot do the embolization of the left tumor. So once we find the vessel supplying the tumor, when we try to take our catheter further into that small branch, because we want to limit the collateral damage to the liver as much as possible. Because if we inject from very proximal in the vessel, like if you see here, this is a tumor in the right liver and it lights up on the angiogram. And if we inject the particles or the chemotherapeutic agent or a mixture of two from here, then part of it will end in the tumor, but a small portion will also end up in the normal liver. So you can get sick after the procedure in the post-embolization syndrome, which basically consists of fever, pain, can be prolonged. So we try to go as selective or super selective as possible, very close to the tumor before we inject the chemotherapeutic agent or the particles. As you see, there's a main catheter here, which is in the celiac axis. And then this catheter has an inner lumen, so then we can place a very small catheter, which is this catheter is about 1.3 millimeter in outer diameter, and then take an even smaller catheter, which is less than a millimeter in size, and we put it through this catheter, comes out of the end, and then goes further out into the small branch, which is supplying the tumor, before we actually inject the particles. Again, to show another example, again, a main celiac axis run shows these multiple tumors in the liver. And this is the little bit later phase, again shows how the tumor light up. So as you see, one of the tumor in the left liver, so we try to go into this small branch which is supplying the tumor. As you can see, this, I don't know that you can see it on this picture, but there is a small tube which goes inside the larger tube and goes all the way out to this branch, and we inject dye and we see it's supplying mostly the tumor, and then we inject the particles, and we do another X-ray after injecting the particles, which is right here. As you see, the blood vessels going to the tumor are completely blocked. So that's how we achieve embolization. Again, same patient. You see another tumors in the right portion of the liver, and we see there's a branch. This is the branch I've shown by arrow, which is supplying the tumor. So then we take a small catheter. It has multiple curves. We have to find that branch. So that's how the X-ray helps us in reaching there. You see this takes this course all the way to the tumor, and before we inject the particles, you want to make sure we do not cause any damage to your normal liver. Because your liver already has tumors, is already compromised, and if we cause further damage to the normal liver, there's a risk of causing a liver failure. We definitely do not want that. And the same tumor is also getting another blood supply from this small branch. It's arising from a different vessel. And then we take a small catheter into that branch, and then we inject the particles. So that's why this procedure usually takes a long time, because we have to individually find either of these branches before we inject the particles. But it's not always possible to be super selective. I mean, in this situation, there are multiple tumors which are occupying almost the entire liver. Obviously, we don't see the situation anymore. This was from a pre-Gleevec era, and when there was no good systemic options available if you develop liver metastasis. These are the kind of patients we used to see about before Gleevec. And in these cases, since we cannot do super selective, we used to inject the particles right from the proximal portion of the hepatic artery. So once we get there, we can inject, as I said, the particles and the chemotherapeutic agents. The chemotherapeutic agents which have been used for this procedure include cisplatin, vinblastine, and some others have been used in some other studies. And there are a number of embolic materials available which can be used. One is iodized oil, which is basically a poppy seed oil. It's partly an embolic agent, but also acts as a vector and carries the chemotherapeutic agent directly to the tumor. And then once we mix the chemotherapeutic agent with the oil, and then we inject into the tumor. And it's also radio-opaque, so you can see it on the X-ray machine. And follow that with some other kind of embolic agent, which can be either PVA, embosphere, gel foam. A number of agents are available, and all of them can be used, and there is no significant difference between these embolic agents. As I said, this iodized oil, it's radio-opaque, so it kind of helps us guide where the chemotherapeutic agent ends up. As I showed you, this is a tumor. When we inject, most of it ends up in the tumor with a little bit of it ending up in the normal liver. And this CAT scan obtained after that shows this very dense white area in the tumor. So that's iodized oil also helps us in localizing the agent to the tumor and following it up. We can do a CT 1 week and 4 weeks later, and if we see a very good oil deposition in the tumor, it suggests that we are getting the entire tumor. If we see a small area which is not getting iodized oil, then we can inject some, bring the patient back, and do another session of chemoembolization. And obviously, you get a little bit of normal liver damage also. Most of them recovers and regenerates. A relatively new development in chemoembolization is drug-eluting beads. The problem with oil is even the oil, though it traps the drug in the tumor, the most of the drug gets released within 24 to 48 hours. So there is no, I would like to see more of drug sitting in the tumor for a prolonged period of time, and that doesn't happen with oil. So these drug-eluting beads, basically they sequester the drug, and then once we inject into the tumor, they slowly release the drug over a period of time. And a number of experimental studies have shown that drug can be released as long as 2 to 4 weeks after chemoembolization. So because of prolonged contact, potentially they can be better tumor kill. So the advantage of the single agent, you're achieving both ischemia because it's a particles, as well as you're getting an increased concentration of chemotherapeutic agent. So far, only a few drugs have been tested with these drug-eluting beads. These are doxorubicin, irinotecan, and oxaliplatin that have been used for, doxorubicin has been used for hepatocellular carcinoma, irinotecan for colorectal cancer, and oxaliplatin has recently been used for cholangiocarcinoma. And some earlier studies have shown the improved response rates with HCC. Unfortunately, we do not have any experience with gastrointestinal stromal tumor, so what we need to do is find a drug which is active against gastrointestinal stromal tumors. At the same time, it has a favorable pharmacokinetic profile with drug-eluting beads. That means the drug-eluting bead should be able to take up that drug and release it. I was just talking to a friend a couple of days ago, and brought up the idea of can we inject Gleevec. Unfortunately, Gleevec is not water soluble and is not amenable to intraarterial injections. So I guess that's something, an area of future research. We need to work on drugs which can be water soluble and can be injected intraarterially and have some action against GIST tumors. Unfortunately, the drugs we have used so far, like cisplatin and belastin, do not have a very good action against GI stromal tumors. Obviously, just like any other procedures, invasive procedure, there can be some potential complications. Post-embolization syndrome, basically you get some fever or localized pain in the area of the liver. This 80 to 90% number is from 5-6 years ago when we used to inject from the main hepatic artery instead of going super selective. And this number has significantly decreased over the last 5 years. We don't get it as we are able to get the patients out within 1 day after procedure. Previously, we used to have to keep them in the hospital for 4 to 5 days after the procedure. As I said, if we cause liver damage, we can cause liver failure, but the incidence of that is very low, less than 1%, and is even lower now that we are doing super selective embolization. Occasionally, an abscess can form in the liver because of hypoxia, again, very uncommon. We can control that with antibiotics. Pleural effusion, you may get some fluid in your chest or fluid around your liver after embolization, again, very uncommon, less than 1% of the time. Since gallbladder also gets a supply from the same vessel supplying the liver, occasionally if a lot of chemotherapeutic agent ends up in the gallbladder, you can get some pain in the right upper quadrant, and basically from cholecystitis or inflammation of the gallbladder. But most of the time we can control that with pain medication, and complication requiring a cholecystectomy or surgical intervention is extremely rare, again less than 1% in previous series, and also in our own experience. Some of the vessels from the liver also supply your GI tract, like your stomach or duodenum, and if you inject a lot of drugs into the GI tract, you can get some nausea and vomiting after that. So what do we see after we do this chemoembolization? So here we see 3 different sections of the liver showing multiple liver lesions, as you can see, involving both right and the left portion of the liver. And we did 3 sessions of chemoembolization. As we said, we don't always treat the entire liver in one session. We do maybe a portion of the liver and bring the patient back in 4 weeks after they recover from the first treatment, do the other part of the liver. So after 3 sessions of chemoembolization, you can see there is a significant reduction in the size of the tumor. As all the tumors have shrunk and look much smaller, they not only look smaller, they look blacker or more hypodense as compared to the pre-embolization, suggesting that we are causing some death of the tumor. But unfortunately, we do not always see shrinkage. Sometimes you see basically because of hypoxia, the cells die within the tumor. The tumors take some time to shrink. As you can see, there was one tumor which was growing, so we treated that tumor and we see that it's become hypodense and necrotic, as we call it, and only a small portion of the tumor is still solid. So the reason I'm showing you this is sometimes the tumor size is right now is the only method of quantifying response. WHO assists all the conventional methods of response taken tumor size. If you use that criteria, there is no response here because the tumor size is same or in fact looks a little larger. Because of necrosis, there's some edema, so initially look at a little larger. So we need to develop newer methods of response to evaluate this to better get an idea of whether we are killing the tumor or not. So if you look at the literature to see how this treatment works, and these are some of the data which was available from before the advent of imatinib, and so these patients did not have the option of imatinib at that time. As you can see, the literature is limited, small number of patients. The largest series, in fact, from MD Anderson. When we looked at our own data, we worked with Dr. Trent to see what our response rate was. So basically, there's one study using bland embolization and 3 studies using chemoembolization, using different chemotherapeutic agents. Although one of the initial studies that came in 1995 showed a higher response rate, but they used a different criteria. If you use a very stringent criteria, as was done in the 2 recent studies, the response rate has been in the range of 13 to 14%. But as I told you, this uses the RECIST WHO criteria basically based on size. So we are underestimating the response here. And that is obvious by the fact that we can actually stabilize the disease in almost 3/4 of the patients, as you can see here. And if you use a newer criteria like ESL, which takes into account necrosis, or another criteria described by Dr. Choi from MD Anderson, I think she talked about that in one of the last sessions, then many of these so-called stable disease would actually come into response by using those criteria. The survival, median survival has been variable, but between 12 to 17 months. If you compare, so we use chemotherapeutic agents in chemoembolization and bland embolization, just particles. There's only one study with bland embolization. And if you see, the response rate is very similar, in fact, a little higher on embolization. So there's nothing to suggest that the chemoembolization is any superior than embolization, at least with the agents that we are using so far, and that's probably not difficult to understand. The agents we are using are not very effective against gastrointestinal stromal tumors. So as I said earlier, we need to look for newer agents that can work against stromal tumors. So when we looked at our own data, we also looked at the factors that affect the survival or the response, because this is very important to know so we can select the patients who are most likely to benefit from these procedures. So some of the factors we found to be affecting or have a prognostic value on this response and survival. This is a survival data, and you see if you have up to 5 lesions, we get overall survival in the range of 22 to 24 months after chemoembolization. But if you have more than 4 lesions, or if more than 75% of your liver is involved, then the survival status is not that high. So up to 5 lesions, less than 75% liver involvement is a higher chance of response and survival. Similarly, if you have extrahepatic metastatic disease, disease elsewhere in your body, then the chance of improved survival is not as high. But if you have a liver-only disease, then we get good survival. Similarly, if you have concomitant imatinib on board, that improves your survival, significantly, as you can see, 43 months versus 16 months. And obviously, if we get a radiologic response or even stable disease after chemoembolization, there's an improved chance of survival. We also looked at a small subgroup of patients in the last few years who were treated after the advent of imatinib, because earlier data was before the advent of Gleevec. And these are small group of patients, only 13 patients, and we did embolization in 6 and chemoembolization in 7, and able to achieve partial response in 7 patients and stable disease in 6 patients with a 3-year survival of almost 45% or 46%. And these are the kind of localized progression that we see after imatinib. And this is like a localized progression. Most of the tumors are still cystic, but there's a localized progression of tumor in one nodule in 1 or 2 lesions. Unfortunately, we also occasionally see non-response or all the tumors progressing. So these are the ones which are amenable to locoregional treatment. Even this we can try to treat, but to treat the entire liver require 3 or 4 sessions, and the chances of achieving a good response is not that high. And again, as you can see, this patient has been on Gleevec. Most of the lesions are stable or responding. There's one lesion which for some reason is not responding and is progressing despite Gleevec. And so we treated with chemoembolization. Post-chemoembolization, see some oil deposition, and so you can see there's tumor looks black as compared to the pre-embolization. That means we have caused tumor cell death. Again, as I showed you, if there are multiple lesions, we can still try to treat it. We did 3 different sessions. Two different sessions treating portion of the right liver, portion of the left liver. There's some oil deposition and see necrosis here. So we're achieving some benefit. But again, you have to, because the entire liver is involved, if we are too aggressive, we can cause liver failure. So we have to weigh what benefit we can provide versus the risk of the procedure. Moving on to ablation, again, it can be used if there's a focal residual disease or focal progression of disease, either in a liver or your peritoneal space. Again, if you're not a surgical candidate. And the way it works is we apply alternating electric current in the body. We place a small needle through the skin into the tumor in the liver, and we connect it to a generator, place a grounding pad to make sure we have a circuit. It causes ionic motion once we start the generator, and it causes heating, and that heat basically kills the tumor. And what we are trying to achieve is a temperature between 50 to 100 degrees centigrade. And if we do that for about 6 to 8 minutes, that kills the tumor. And these are the different configurations of the probes that are available that we use from different companies. And there's no significant difference in terms of effectiveness of these probes. And just like surgery, when we take the tumor out, they try to take a portion of the normal liver around it, because what you see on radiology, there's some microscopic cells which are not seen in radiology, which are extending outside the tumor. So we try to kill a portion of the liver about 1 centimeter all around the tumor. So depending on the size of the tumor, you may need one ablation or you may need multiple overlapping ablations for larger lesions. Generally, we can treat up to 3 or 4 centimeter lesion. Up to 3 centimeter lesion, we are sure we'll get the entire lesion, depending on the location, of course. But if it's more than 3 centimeter, we have to see the location, what are the surrounding structures. The chance of getting complete tumor cell death will be not less than 60%. We can use either ultrasound or CT to guide our procedure. You can see a probe has been placed in this tumor, and once we start heating, this ecogenic bubble forms because of the air that gets generated and then completely covers the tumor. Sometimes we use CT for difficult locations. There are only few studies available for use of radiofrequency ablation especially for GIST tumors, and small number of patients, but in one of the studies they saw response in as many as 12 out of 13 patients and stable disease in one patient. So basically I'll end here to conclude that Gleevec is the first line treatment, and because of this emergence, the role of local regional treatment has decreased over the years, but still has a role in patients who develop primary or acquired resistance to Gleevec, particularly suitable for patients who have initial response but start progressing in 1 or 2 areas they can selectively target. Thank you, and thank you for your kind attention. So if there are any questions, we will take them.
Doctor, did you say this works on tumors that are just under 3 centimeters? Is that correct?
No, as I said, I mean, for ablation, the chance of getting complete tumor cell death or completely eradicating the tumor is high if it's less than 3 centimeter. If it's more than 3 centimeter, you can still debulk the tumor and sometimes even get complete tumor eradication, but the chances of getting that drops because, as I said, the ablation zone varies depending on the overlapping ablation. If you have a important structure sitting right next to it, it would be difficult to ablate the tumor without risking injury to that structure. So complete tumor eradication is possible with 3 centimeter. After that, you can debulk the tumor and maybe get 75% tumor cell death, but complete tumor cell death may not be possible.
All right, thank you.
Hi, doctor. I have a question about radiofrequency ablation. I wanted to know what determined laparoscopy versus laparotomy.
So you mean surgery versus radiofrequency or different methods of using
Different
radiofrequency?
methods of using it, because you say that it can be done laparoscopically or...
So radiofrequency ablation or any ablation, as I said, other than laser microwave, or basically involves placement of a needle into the tumor. Now the placement of the needle can be done either by radiologists using interventional techniques when we place the needle through the skin without opening up the abdomen, or it can be done intraoperatively when the surgeons do it. Surgery, they open up your abdomen, and then once they have access to the liver, they place that same probe in the tumor and then do the ablation. So both can work, but obviously percutaneous method is less invasive. But there are certain situations when the tumor is in a location when I cannot access it percutaneously. Then surgeons, if they open up, they can expose the entire liver, even can reach those lesions. So those are the areas when they do surgical ablation, when it's in an area of the liver that I cannot access percutaneously.
Because I will probably have RFA in a couple of months, because I was diagnosed in December 2008, was on Gleevec until July of 2009, and I had surgery, extensive surgery, where Dr. Di Matteo removed about 70% of my liver, was probably about 99% of the tumors. And last month, I have 2 tumors in my liver that's starting to grow. They're fairly small, like less than a centimeter. And now I'm on 800 milligram Gleevec, but they still think that I need to have that RFA done. And I just wanted to know.
As I said, both options are possible. In our institution, what we do is generally most of the patients are done percutaneously using image guidance. Only if there's an area which we think we will not be able to get it, and surgeons can do a better job because they open up the abdomen, they can mobilize your liver and get access to areas which we cannot access. Although that number is kind of going down now because with innovative technologies, with so many advancements in technology, we can get to almost all portions of the liver. And the advantage is it's not an open procedure. You don't require a laparotomy. You can just put a needle through the skin without making any incision. So we can do the image guidance. So those are the advantages. Simple. Yeah, you're right.
Thank you very much.
Doctor, if you're not getting good response rates, is there a point in time where people look at...
Sorry, where is this? Okay.
A point in time where people would look at the possibility of liver transplants, or is that not considered? And if so, would a transplant help some of those patients?
Again, I don't have much experience with transplant, and I don't know whether Dr. Trent would like to take that question, if transplant is an option at some stage if it's not responding.
So regarding transplant, it's not generally done in the setting of metastatic disease because there is a higher probability that there is GIST cells in the peritoneal cavity or elsewhere in the body. So from my experience discussing this with the surgeons, the transplant surgeons, it's not something that they have been willing to do. But if there is a situation where, for whatever reason, it makes sense, then it's certainly reasonable to discuss the case with a transplant surgeon regarding the risks and the benefits, because it's not a risk-free procedure. Are there any other questions? Yeah.
Have any of these other procedures been done in other tumors outside of the liver? In any of the organs?
As I showed you in one of the slides, there have been, very small number of patients in which ablation has been used for small localized peritoneal disease. I'm specifically talking about GIST tumors, although ablation is used, and we use it for non-hepatic areas like lung, if you have a tumor in the lung, and if that's the only area is progressing. Pulmonary RF ablation is now established procedure, and we do it. We do it in the kidney, we do it in the musculoskeletal system. So the 4 common sites we use is liver, kidney, musculoskeletal system, like bone tumors, primary or metastatic, and lung tumors, primary and metastatic. Specifically for GIST, apart from liver, there have been few reports of small isolated peritoneal disease.
Oh, I was wondering, now there's been a lot of talk about the cyberknife and now the nanoknife procedures, and I was wondering, is there some time in the near future where they'll be able to be used on GIST tumors?
So cyberknife is basically radiation using stereotactic radiation, and gastrointestinal stromal tumors are not very radiosensitive, as I was talking to a friend a few days ago, and that's what he told me. So I don't know. Cyberknife is just a method of external radiation which allows very, very controlled delivery of radiation as compared to conventional radiation. If you give a very high dose, some of the tumors could respond, but again, there is no literature to show whether these tumors will respond to that kind of treatment. And Dr. Trent has something else to.
So using those types of local therapies, such as cyberknife or gamma knife, I'm sorry. So using those kinds of therapies, it makes sense in a few situations. For instance, if there's only one site, so it's very limited, and it cannot be resected surgically, or any of these other procedures that Dr. Gupta has discussed are not applicable, then that might be something to consider. And the other time to consider it is if there might be widespread disease, widespread GIST, but there might be one area that's causing pain to a patient. So that's another time to consider it. But from our experience, the dose, it takes a very high dose of radiation to be able to kill GIST cells. Standard doses don't seem to be so effective, so you have to use the higher end of therapy. And those higher doses of radiation are often not possible in the GI tract or in the liver. So it's almost impossible to do that in those areas because you'll do too much damage to normal tissue. But it can be done, for instance, with bone metastases or in areas where there's not a lot of other normal tissue, or the normal tissue can stand higher doses of radiation. So there are rare examples where it can be done, and if it sounds, if the clinician thinks that it sounds like a reasonable approach, then it's worth discussing with one of the specialists who does that type of radiation. So I think it would be, there are times when I discuss these cases with radiation therapists, and it makes sense occasionally.
Now, this is a question from a non-medical person. We've read the radiologist report over the last year, and we see what is very definitely a measurement that the radiologist has done on the GIST tumor down to the centimeter. And my question is, over time, how can a radiologist always measure something that's meaningful in terms of shrinkage? Because it appears that the tumor or any of the tumors that are being measured don't shrink in a uniform manner. They would shrink in asymmetrical progression. What does a radiologist do about that? Do you understand what I'm saying?
Yeah, I understand what you're saying. So, as I mentioned, that's actually a very good and excellent question, because there's considerable debate going on in radiology and even in oncology literature to how to assess response, because that's very important to know whether you're responding to a treatment or not responding, but that determines whether we need to change treatment, increase the dose, or think of some alternative methods of treatment. So currently available, which are universally accepted criteria of responses, as I mentioned, is the WHO criteria and then more recently the RECIST criteria, which all of these only take into account size. Again, as you mentioned, the size is not an easy thing to measure because the tumor may be shrinking from a small portion and taking a different shape, but if you do only cross-sectional diameter, that may turn out to be the same, or even larger or smaller, but actually it may not be a very good indicator of response. So one way people are doing is volumetric assessment. Basically, there are softwares available which are labor intensive but can be done when you, instead of doing just 2 dimensions, you do a CT and then you measure the volume based on certain software, so you get the very accurate idea of the volume of the tumor. And that could be a better way of assessing response. But again, they are not universally, it's difficult to use them, it's very labor intensive, and the reason people are not using it just because it takes too much time. And also, there's a certain degree of response that you need to see, this is called partial response, more than 50% decrease in size, and there's a minimal response with less than 25% increase in size. So whether that's going to effectively change your management is something we need to see. That's the reason people have not moved into volumetric data right now, but that's something which can be done. Yes.
Is there a limit to the number of tumors that can be treated with RFA? And also, if it's that effective, why not treat all the tumors, even the ones that are responding to Gleevec, before they develop resistance to Gleevec and start growing again?
Yeah, I wish we could do that, but technically it's generally we've seen up to 4 or 5 lesions is something we can safely treat. And also, it's not only the number of lesions. I mean, if they are in a suitable location, I've also treated up to 6 or 7 lesions. So they're small lesions. So the number is various. There's no absolute number that we can say above this we cannot treat it. If they have small lesions in a good location, not close to major structures, then you can treat even up to 6 or 7 lesions. But generally, we say 5 lesions is what we would like to treat. Anything more than that may require 2 or 3 sessions because it becomes too invasive and can cause side effects. So sometimes we do it in 2 or 3 sessions. So as I said, up to 5 lesions, occasionally more than that. So your second part of the question is to treat them even before they develop. The Gleevec has such a good response rate, and this procedure is not RFA is not without any risk involved, so that we need to use it only when it's necessary to do it. Because you can develop growth even after, or recurrence in other portions of the liver even after ablation, because ablation is directed towards one tumor. Unlike liver, which is systemic therapy, is not directed towards the entire body. So it's a local treatment. You are basically treating one tumor, but you can still develop tumors in the rest of the liver. So you have to, so treating them even before they develop resistant gleevec doesn't make much sense.
Are there any other questions? I guess I'd like to make a comment, and maybe Dr. Gupta will comment too, but one thing that we frequently do is take a multidisciplinary approach at these situations. So the patient may end up seeing a surgeon and an interventional radiologist and me, sometimes a radiation therapist too. And so, for instance, the patient may have a liver lesion that's not resectable, but has a primary tumor that is resectable. And so the surgeon might resect the primary tumor, and then Dr. Gupta might treat the liver lesion through interventional radiology methods such as embolization or RFA, and then we might also use systemic therapy. So I think it's a very important part of the entire GIST team, having experienced interventional radiologists like Dr. Gupta and experienced surgeons, and it all it all comes together in a multidisciplinary GIST setting. So I think it's a team approach is the best approach.
I agree with that. I mean, obviously, as I said, there are situations which happens, and we have done that when the surgeons take out the primary tumor and we go for an area in the liver or in different portions of the body and do either embolization or ablation. So multidisciplinary setting is very important so that we can discuss with different specialists in different fields and decide what is the most appropriate method of treatment.
Does it make more sense to use RFA and then the tumor is gone, or to try to remove it and test it and see what it was? Does that matter? If you see the mutation of that one lung tumor?
Well, the mutation issue is it's somewhat complicated. And one of the problems for the secondary mutations is that if the patient has 3 liver lesions, they may all 3 have different secondary mutations. If there's a solitary liver lesion, then if it's resectable, then the patient will often have it resected. If it's not resectable, then we will sometimes biopsy before the patient is treated with RFA or embolization to gain information about the secondary mutation. But often, if the biopsy is risky for any reason, I don't pursue that aggressively because it can be helpful, but it's the data on which drug to treat which mutation with is still somewhat emerging. And the other thought is that you're going to treat that tumor anyway. So whatever that mutation is not that important because that tumor is going to be taken out or treated by RFA or embolization. So that tumor that has that specific secondary mutation is going to be gone and treated. And whatever that mutation was is somewhat independent of other secondary mutations. So the utility is something that we're still struggling with. I suspect it will be important in the future, but today we're still struggling on how to handle those situations.
Okay, thank you very much.